So as Yelena introduced me, I'm Maria, and I work with my colleague Jenny Tanton at Great Ormond Street, and we're the transplant coordinators there. So as we all know, preemptive living donor renal transplantation improves the morbidity and mortality of children with end-stage kidney disease and is widely accepted as the gold standard for renal replacement therapy. So just to talk a little bit about the background at Great Ormond Street, we did our first living donor transplant in 1990, and we approximately transplant between 20 and 35 children per year. We have about 100 recipients on our books, so to speak, and about approximately 80 donors come forward to talk about or sort of think about donation. We look after children within the NHS, children from other centres with complex needs, children from Europe, and children from in our international private patient programme. Children should be approximately 10 kilograms for transplant, and about 15 months of age is the earliest that we can transplant at. Whoops, that's jumped, sorry. So just looking at our transplant numbers since 2009, as you can see, we predominantly do living donor transplants, and partly because we seem to be getting less offers on the deceased donor list, and also, whoops, it's jumping, because we very much promote living donation, as I'm sure everyone else does. You can see 2020 to 2021 was our COVID year when we had to close our programme for some time, and then 2021 to 2022 we worked very hard and caught up, which was quite a tough year. So just to look at the workup for the recipient, so of course you want to know their blood group, the HLA typing, which is done here at Guy's Hospital, and the HLA antibodies. For living donors, we'll do an initial cross-match with the donor if the recipient has HLA antibodies, has had a previous transplant, or if CTL here advise us to do so. And we'll do ABOI titers if we think we're going to have to do a blood group incompatible transplant. All children have to be fully vaccinated prior to transplantation, so not only their routine childhood vaccines, but we also ask for varicella if they're measles negative. We don't insist on COVID, but we do actively encourage it. And we don't ask for a BCG now. Some children have a BCG if they're born in an area where they need a BCG, but we don't ask for that. I'm not talking quickly enough for my slides, sorry. We check everyone's virology. If they're varicella or measles negative, we'll ask for a booster in those vaccines, and all children have to have Hep B vaccine. Handily, now with the new vaccine programme, all children have Hep B with their routine baby vaccines, which helps us enormously. But we have to play catch up with the older children who haven't received those Hep Bs. We'll do all the children's coagulation, a basic screen initially. Then if there's a disordered result or there's a family history of bleeding or clotting disorders, we'll do a full thrombotic screen and ask for haematology's opinion if we need it to think about anticoagulation post-transplant. We'll look at the liver function and we'll do a fasting glucose or HbA1c if we deem to be high risk. Looking at their imaging, they all have an abdominal vessel ultrasound to ensure patency of the vessels, and latterly we're now looking at the size of the vessels to make sure our surgical colleagues are happy. If the children are quite small, we used to say under 20 kilos, but we don't insist now. The children will have an MRV. If they've had previous femoral lines or if we see any occlusion in the ultrasound, then we'll proceed to an MRV as well. Sometimes we do a neck ultrasound if they've had lots of previous access. They all have an annual echo, and they all have a bladder ultrasound to ensure their bladder is safe and empties to completion. And will the bladder cope with the increased urine output post-transplant? And then just to think about, is the patient anephric or do they need nephrectomies prior to their transplant? So urology, I won't say too much because I'm sure Mr. Mushtaq can say far more than me. So we just want to know that their bladders are safe for transplant. And a lot of our children come to us through urologies. They've already had urology referrals and urology plans. So they might have a bladder fill assessment or formal video urodynamics. We ask for our urologists to be very much involved in the MDM process, and we like sign off with a urology plan for all our urology patients. We ask that all children are regularly checked by dentists, which is getting more difficult with the NHS dental provision in the UK at the moment. Some of them have an anaesthetic review, but they're all reviewed at our MDM anyway by the anaesthetist prior to transplant. Do other specialities need to be involved? For example, liver, cardiac, metabolic? If they do, we sign off that they're happy that we're proceeding to transplant. If it's a small child or a complex child, do they need a PICU or CICU bed? For living donation, this needs to be requested in advance. Some children need an extended and all-day theatre list, more the small children, the complex children. So we have to negotiate with our theatres as if we can have an extended list. All patients have to go through the MDM planning meeting, and everyone has to be signed off by the consultant. We also ask for help from our psychological colleagues. So they all have a psychosocial assessment, so all families pre-transplant should have this. And they look at the practical aspects. For example, if it's a living donor transplant, one parent will not be on site or around to look after siblings. And also thinking about parental responsibility. If you've got a parent who's donating and the other parent isn't the biological parent, do they have the right to consent? We think about care of siblings, loss of earnings, and the impact on the whole family that transplantation has. We discuss the follow-up, which is quite rigorous in the beginning, and are the family on board with this, and can they cope with this? And we also very much involve our play specialists with our preparation. So nearer to the time of transplant for the living donors, they'll meet with the consultant transplant nephrology clinic, which we have a monthly clinic there. And they also meet with the transplant surgeon. And more often than not, they'll meet with the transplant surgeon more than once. The nurse specialists, we do preparation discussions, quite rigorous and more than once, just to make sure the families understand the preparation involved with transplant, and what the post-op follow-up is and what we expect of them, what the meds are, the do's and don'ts post-transplant, and the plan for return to school, etc. And as I said, these discussions are very much ongoing. They're not a one-off conversation. Once we're happy to proceed to transplant and our colleagues at Guy's are happy, we'll confirm the date with the lead surgeon, with the ward and the family. We'll book PICU, send our email out to the whole team, book the hotel for the children post-transplant, and book the final flow crash match. And then we offer the families to visit the patient hotel, the ward, ITU, if they're not familiar with those areas. More often than not, with our preemptive transplants, many of the children haven't really been onto the ward before, so it's good for them to see that. For living donors, we see the children the week prior to transplant, where they meet the surgeon again, and surgical consent is signed. We'll do a final flow cross match with the recipient and the donor, a baseline chest X-ray, and then we'll finalise the admission plans and any needs the family have. Consultant will sign off the protocol, and then everything goes up to the ward, and hopefully the patient is ready to go. With COVID, we now ask the families to shield for a week prior to transplant, just to reduce the risk of them catching any coughs, colds, flus, or COVID, etc. So we don't have to cancel the transplant. For children who are going to be activated on call, we'll send HLA antibodies, we ensure their protocol's up to date, signed off. We'll do on-call CNS talks, very similar to our living donor talks, and then we'll register the children with NHSBT. Once they're activated, we confirm this with the family, we confirm it with the ward team, and while they're on call, they have annual surgical reviews, annual echoes, and 3 monthly HLA antibodies sent, so that we've got up-to-date results on them. As I said, about 80 potential donors are presented to us throughout the year. So they normally meet myself or Jenny first, and we'll just discuss living donation with them, and just see, are they diabetic, are they hypertensive, what's their BMI. We'll give them a registration form. Once they've returned that and we've registered them, we'll do blood groups and HLA typing. Very particularly have to explain the HLA typing test, because we've been caught out over the years where dad isn't dad, and that's been quite a tricky situation. So we're actually in the process of developing a consent form with our trust solicitors before we take this test. We give them the information, transplant information they need, and once we get the results back, we refer them on to the lovely Anita at Guy's. We have lots of families asking about donors from overseas, so we'll see if we can get a blood group from them, see if we can get HLA typing. It can be very difficult to get HLA typing from certain countries, so sometimes they're posted over to us, they get lost in the post. It'd be quite a lengthy process. But if we get the results back and they're good, then again we'll refer them over to Anita, and they'll start their workup from overseas. So with the donors, once we refer them over to Guy's, they must make contact themselves with the Guy's team, and we very much explain that to them. And then from then on, all the donor workup is done at Guy's. So we just do the recipient workup, and the Guy's team do the donor workup with Anita. We work very closely with Anita. We hand over weekly to her and very much keep both teams updated with where we are with the recipients and the donors. The donors have a thorough medical and psychological assessment, starts with an initial discussion, medical tests, and then they may need to proceed to biopsy, cystoscopy, etc., which delays the workup for them. Once they're signed off at Guy's, they have a final independent assessment appointment, and where both donor and recipient and a representative of the recipient have to attend. More often than not, this is now done on Zoom as opposed to face-to-face. We also get quite a few complex out-of-centre overseas recipients, often referred to us from Scotland, Wales, Ireland, Europe, the Middle East. And some of these complexities include surgical challenges, comorbidities, complex urological challenges, and MMA. And in fact, Jelena has been very active in setting up an MMA collaborative network incorporating Great Ormond Street Kings, Guy's, and Evelina. And each case brings its own challenges, both surgically, medically, and I think more often than not geographically, because you've got another team involved and it's quite hard to get everything organised. So looking at the way forward and what can we do to expand living donation and obtain more living donors. So we nearly always have someone in the National Living Donor Kidney Sharing Scheme, and that's a quarterly national run managed by NHSBT, and it includes paired and pooled donation, and it's for recipient pairs who are HLA-I or ABO-I. So 2 pairs in the scheme is paired donation, more than 2 pairs is pooled donation, and it's all worked out on an algorithm so they can match and maximise the pairs. I do find that some families of donors are very reluctant to consider this. They're happy to give a kidney to their child, but the thought of giving a kidney to someone else they're not so happy with, even though their recipient may receive a living donor kidney. But we refer them over to Anita, have a chat, talk about the scheme, and if they want to go forward, they can. So I think Jen and I have really been thinking about increasing education around this scheme because it is really fantastic. We put limits on our recipients, so age, mismatch, and this can all reduce the chances of the children being matched. But we have had quite a few successful matches in this scheme. We also have altruistic donors who come forward. So that's an anonymous, non-directed altruistic donor to a recipient on the waiting list. And they can be registered either into the National Living Donor Scheme to start an altruistic chain, or they can donate directly to somebody on the list. So sometimes we get phone calls from people saying, I want to give a kidney to someone. So we'll either direct them to the NHSBT website with a really good section there on how to register, or we'll speak to our lovely colleague, Guys. We can also do blood group incompatible transplant, where we transplant across the blood group barrier. We don't initially start with this. We'll always advise 3 runs in the sharing scheme first to see if we can get a compatible donor. And we'll consider an ABOI transplant if their titers are low enough. If they are, then we need to plan an individualised plan regarding immunosuppression and either plasma exchange, DFPP or IA, depending on their titers. We can also consider HLA-I transplant. So transplantation when recipient antibodies are present against donor HLA. So again, we'll take advice, particularly from our clinical scientists at the lab at Guy's, nephrologists and our adult colleagues regarding a tailor-made immunosuppression protocol, and very much discuss with the families, with this and with ABOI, risk versus benefit and the risk of increased immunosuppression with these transplants. So historically, we always accept a 111 mismatch for living donor, and initially a 110 for someone who's placed on the list for deceased donation. And then once a child had been on call for a year, we reduce their criteria to a star 1 equals 3. So this means we'll accept a 1 or 2 antigen mismatch on the A or the B, but only 1 mismatch on the DR. Will still equate to a 3 antigen match. However, we have changed our practice, and I believe Evelina have as well, in that if a child has match points of 5 or over, we will now list them initially for a star 1 equals 3. The waiting list now seems to be about an average of 2 years. The children are waiting a very long time, ending up on dialysis. Sometimes with living donation, we'll accept a 2-antigen match from a very fit, healthy donor after much discussion with the team and with the family. Social media campaigns are becoming increasingly more popular, and the HDA have said it is not illegal to advertise for an organ as long as there is no offer of a reward, payment, or material advantage. And this can incorporate directed altruistic donation. And a framework is being looked at nationally because I think everyone approaches it slightly differently, and we have asked for a national framework for guidance. And it very much requires collaborative work with your donor and recipient team, because you can have numerous people phoning up, and it can be a lot of work. So just to say, we've started doing a theatre open day, which we try to run 2 or 3 times a year, where we invite the children to theatres on a Saturday morning. The theatres are opened up. We do it in with the cardiac team, and this is a really good day. They can dress up, they can scrub, they can pretend to suture. We have the mannequins where they can intubate, ultrasound, etc. And they find this a really, really worthwhile day. So improvements, we're always trying to improve what we do, make it better. So we continuously audit our practice. Any child who dies, who has an unexpected outcome, will have an M&M. We constantly look at our preemptive rates. Can we improve them? Were there any patients on dialysis who could have received a preemptive transplant? If so, why didn't they? Are there any delays or barriers to listing a child on call? And as I said, we're drawing up a consent for HLA typing. And just lastly, I was quite excited by this. There's a JCVI, the Joint Committee on Vaccination Immunisation, are recommending a universal varicella vaccination programme to be introduced as part of the routine childhood schedule. And it should be a 2-dose programme offering vaccinations at 12 and 18 months using the combined MMR, so it'll be the MMRV. And I know Kate and myself would be delighted if this happens, because we have to do a lot of work with catch-up with vaccinations and trying to persuade GPs that this is their job, not ours. So that's a bit of a whistle-stop tour to preparing a child for transplant. Hope I haven't spoken too quickly. Thank you.
Thank you, Maria, for a fantastic.
That really was fun, wasn't it?
Something.
Any questions?
Do we have any questions?
For Maria from the audience?
Anybody? It won't bite, this microphone.
That would be nice.
So, well done to start with. I suspect that the people who call you and say, I want to donate a kidney, most of the time they say, I would like to donate a kidney to a child. Is that something that can be directed to an HSBT, or it just goes in the general pool?
You can't altruistically donate to a pool. So you can either altruistic donate to an individual, so someone you see on a Facebook campaign, on the news, etc., or you have to altruistically donate to anyone. Because therefore, someone could phone up and say, I want to donate to a child, I want to donate to a female under 16. So that's right, isn't it, Anita? Yeah. So it's either an individual or anyone.
Thank you. Anyone else? No? Okay, thank you very much, Maria.